رقم 2 للurinary system،
Recording in progress.
إن شاء الله زي ما تعودنا هنعرض بعض الحالات ونستنى التعليقات بتاعت حضراتكم، وبعدين أنا I will comment، وبعد كده كل واحد عنده حاجة عاوز يسأل عليها ممكن يكتبها لحد لما نخلص، وبعدين يسأل فيها، ما يجراش حاجة إن شاء الله. توكلنا على الله. And this is the first case of male 50 years old with altered bowel habits. Yes, and the answer came to me is diverticulitis, and actually this case I put it here to say something about the issue of diverticulitis. You know that we diagnose diverticulitis by the presence of patent diverticuli with narrowed colonic lumen and the stranding of the pericolic fat. Then you have to know that diverticulitis or diverticular disease can be complicated by malignancy. And this malignancy, number one, will obliterate almost totally the lumen. Then it will destroy the diverticuli, and you cannot see in the affected segment any of the patent diverticuli, maybe one or two. Then this diverticulitis or malignancy on top of diverticular disease can fistulate with the urinary bladder, and that's why you can see air bubbles in the urinary bladder. And you should know that sometimes you are not dealing with a simple diverticulitis. You may be dealing with malignancy on top of diverticular disease that has fistulated with the urinary bladder. Then how to judge this possibility is to look carefully for the affected segment, and you cannot see divertically in the region of the tumor. The second case. Yes, transitional cell carcinoma, okay. And you got diffuse non-uniform thickening of the urinary bladder, as well as intravesical polypoid mass. And sometimes you can this position we may put the patient in the prone position sometimes to see clearly if the tumor has infiltrated the seminal-vesical angles or the related fat. Because in the prone position you can see that the bladder goes more anteriorly, and you can see or judge carefully the clearness of the perivesical fat. This is a bladder cancer or urethral tumor. Next case. Left pyelonephritis, good answer. And this is acute pyelonephritis on the left side. The left kidney is swollen and the function is poor, and you got some stranding of the perinephric fat, and the start of the formation of renal parenchymal abscesses, and these are the small buckets of fluid-like density surrounded by marginal enhancement. and this is diagnostic of acute pyelonephritis on the left side. Good. This patient with prostatic cancer presented by difficulty in micturition, and the ascending urethrogram showed this area of narrowing. What do you think about? Yes, urethral stricture and urethral stricture. Okay, and I have mentioned many times, and I have to mention also several times, that whenever you know that the patient had a primary malignancy, you should correlate between the findings you are seeing and the patient malignant condition. Then you see that the patient had prostatic cancer, and there is a stricture in the urethra, and this was a metastatic deposit in the urethra that has resulted in this type of stricture. Then you may say, how can the prostatic cancer reach the urethra? It's by blood-borne metastasis. Then whenever you know that the patient had the primary malignancy, you should think first of metastatic deposits. Then whenever you are asked about the differential diagnosis, you can mention anything else. And next case. Yes, there are right answers about meds, and then this case is a syringocele. This is good answer. This is a urethral syringocele or Cooper duct syringocele, which is a cystic dilatation of the main duct of the bulbourethral glands, and this may result in post-voiding dribbling, frequency, weak stream, or even hematuria. The cyst is usually unilocular and is located along the posterior or posterolateral aspect of the urethra, and the treatment includes surgical excision of the obstructed duct. Next case is an MRI of the prostate, and this is stair images, this is diffusion, and this is ADC. Benign prostatic hyperplasia, cancer prostate. Yes, the right answer is prostatic cancer, and you see that the prostatic cancer is usually located in the peripheral zone, but it can also occur in the central zone. In the T2 weighted image, it is characteristically of low signal against the bright signal of the peripheral zone. In the diffusion weighted images, the lesion showed diffusion restriction, bright in the diffusion weighted images, and dark in the ADC map. This is the classic appearance of a peripheral zone prostatic cancer on the right side. And whenever you reach this diagnosis, and you have to say, is there any possibility of extra prostatic extension? And is there any possibility to involve the neurovascular bundle, which is usually located along the posterolateral aspect of the prostate on both sides? As you all know that everything has now the BI-RADS categorization or classification, and this is the BI-RADS of the prostate. They said that BI-RAD 1 is most likely benign, and this requires only the clinical follow-up. BI-RAD 2 is probably benign, then clinical follow-up and BSA plus or minus multiparametric MRI. Actually, I do not recommend the multiparametric MRI because it is a lengthy procedure and costs a lot of money. Actually, we depend many times, if not almost all the times, on the axial T2 weighted images, And then we go to the diffusion weighted images to separate infection or inflammation from neoplasm, but we do not usually do MR spectroscopy or the dynamic contrast enhanced scan. BIRAD 3 is an intermediate, and it depends on the clinical suspicion, and the clinician may decide if he should go with the clinical follow-up or go to the biopsy. BIRAD 4 is probably malignant, go for biopsy. BIRAD 5 is diagnostic of malignancy, go for biopsy. Next case. This is MRI sagittal T2 fat sat image showing this is the urinary bladder and this is the vagina. Then the diagnosis is very easy now, and uh, Uh, the diagnosis is rectovesical fistula. I will try to answer the side questions at the end of the talk, not to make some disturbances. You see that there is a connection between the urinary bladder and the vaginal vault, a diagnostic of vesicovaginal fistula. These are the causes of vesicovaginal fistula, like prolonged obstructed labor, surgery like hysterectomy, pelvic malignancies, radiotherapy, uterine rupture, or other risk factors like trauma, pelvic inflammatory disease, and diabetes. Actually, we used to diagnose the vesicovaginal fistula by IVB. Whenever you inject the patient with contrast and wait for filling of the urinary bladder, and you can see something which is filling also with the urinary bladder. If you have the lateral view, you can easily appreciate that this is the vagina. And this is the sagittal reformatted CT image showing clearly the urinary bladder and the vaginal vault. This is the uterus, and you can see the vesicovaginal fistula. Next case is an ultrasound of the testis, and I have to say that the best the best modality for evaluation of the testis is ultrasound and Doppler. And the role of MRI and CT are extremely limited in this particular disease. There are two possibilities here, seminoma and orchitis. Then we have to differentiate between both. Both lesions can show increased vascularity on Doppler images. But the seminoma is a focal pathology, while orchitis is a diffuse pathology. Then if you can see a particular what looks like a mass, whether it is relatively ill-defined or well-defined, then you go for the diagnosis of seminoma. But if you see that the testicle is swollen and diffusely involved by Doppler evidence of hypervascularity, then at that time uh, uh, you may say the possibility of orchitis. And usually orchitis is associated with epididymal inflammation, and this helps in the diagnosis. If you see also color Doppler vascularity in the epididymis together with the testis, and this will simplify the diagnosis as epididymoorchitis. But in this case, you got a localized lesion in the testis, and it is seminoma. And you know that seminoma is the most common testicular neoplasm in this age group. It is relatively younger than any other genitourinary tract neoplasm. Testicular cancer is uncommon, and it accounts for less than 1% of all internal organ malignancies. 90% of the tumor of the testis are primary germ cell tumor, and the diagnosis depends on the age of the patient. In the first decade, you expected yolk sac tumor and teratoma. The second decade, choriocarcinoma. The third decade, embryonal cell carcinoma. The fourth decade, seminoma. And the seventh decade, you consider lymphoma. A lymphoma and this special type of seminoma, which is known as spermatocytic spermatocytic seminoma. Then this is the appearance of a seminoma and the age incidence, as I have mentioned, and approximately 45% of germ cell tumors are seminomas. Seminomas may be bilateral in about 2% of the cases, and there are almost always asynchronous. And that's to say, they do not occur simultaneously and at the same time. Trauma may draw the patient attention to the presence of a testicular mass. There may be back pain, abdominal mass due to lymph node deposits. Distant metastasis and extranodal deposits are rare. There are three subtypes of seminoma: the classic type, which is the most common, anaplastic type, and spermatocytic type, which is the least common. This is the appearance of seminoma on ultrasound, a focal mass within the testis. If you have the Doppler images, then you can see high vascularity in the tumor. Ultrasound features include homogeneous intratesticular mass of low echogenicity. The mass is usually oval, well-defined, in absence of local invasion, confined within the tunica albuginea, rarely extending to the paratesticular structures, and there is internal blood flow on color Doppler. Cystic changes and calcification are less common. Next case. This is a female patient aged 43 years old. A urothelial tumor, very good, but you should say that it is multifocal. Then if you look carefully here and you see multiple lesions in the renal pelvis, another focal lesion in the proximal ureter, and a third lesion in the distal part of the ureter. You know that transitional cell carcinoma can be multifocal, and whenever you diagnose transitional cell carcinoma, you must screen the whole urinary tract looking for other lesions, and this is very important for the diagnosis. Transitional cell carcinoma is now known as urothelial, or the better name is urothelial tumor, and it represents about 5 to 10% of the renal tumors, more common in males at the elderly age, uncommon compared to the renal cell carcinoma, which is more common. The tumor arises in the renal pelvis or in the calyces, and the patient may present by microscopic or macroscopic hematuria. Urine cytology is insensitive for the presence of malignant cells, and the majority of renal pelvic urothelial tumors are low grade and of good prognosis. Then if you look here, and you can see a filling defect in the renal pelvis, which has many possibilities. On top of these possibilities, the transitional cell carcinoma, and another focus in the urinary bladder. Transitional cell carcinoma rarely present by a large mass lesion. Tumor calcification is rare, and in order to detect this particular lesion, you have to opacify the pelvic ileal system adequately with intravenous contrast material, and this may be obtained by conventional IVB or CT urography or antegrade biography or retrograde biography, anyway, but you ensure adequate opacification of the collecting system. The appearances of transitional cell carcinoma on images include filling defect in the renal pelvis or calyces, distortion or disruption or amputation of the calyx. Lesion may obstruct the pelvis, results in hydronephrosis, non-functioning kidney, not necessarily with hydronephrosis, a calyx which is distended by a tumor known as oncocalyx, and a calyx that is not opacified by contrast is known as phantom calyx. All these signs I think I have mentioned in the original lecture. Then the next case is the male, 43 years old. Yes, renal trauma and injury, renal injury hematoma. Um, okay, yes, but you have to say the grade of actually this is renal laceration, and you got a big perinephric hematoma. If the laceration is more than 3 centimeter, you consider grade 3. If the lesion has reached the pelvic system, and this is grade 3 also, then you expected that this is grade 3 renal injury. Next case, cystic renal cell carcinoma, no. And actually, for the diagnosis of cystic renal cell carcinoma, you have to see cysts as well as a solid component. But this lesion is in the form of multiple loculi, and it extends outside the confinement of the kidney, associated with obliteration of the renal fat, and this is diagnostic of renal abscess. Okay, this is not fat to consider angiomyolipoma. This is fluid. Okay, maybe the image is not that good, but this is a renal abscess with perinephric extension. Renal abscess is a fluid that or the collection containing pus may complicate pyelonephritis, as I have mentioned. If you see gas within the collection, this will help you to reach the diagnosis. The risk factors include diabetes, renal calculi, and ureteric obstruction. The presentation is by fever, flank pain, chills, and dysuria. And this is the classic appearance of a renal abscess. This abscess may be unilocular or multilocular, as you can see. It may extend outside the renal parenchyma into the para or perinephric space. Before the abscess liquefies into a true cavity filled with pus, it is known as acute focal lobar nephronia, meaning that inflammation of the renal parenchyma forming this particular focus, which will later on liquefy into the abscess. Then anyone can ask, how can I discriminate this from a renal cell carcinoma? The answer, number one, is to consider the clinical picture. Inflammation means fever, means chills, means pus in the urine, and so on. But the renal cell carcinoma will maybe not associated with any symptoms or sometimes by hematuria. Number two, in the images, the renal cell carcinoma is not usually associated with stranding of the perinephric fat and thickening of the gerotta fascia unless the tumor is large enough to invade the perinephric fat. Then you depend on the clinical picture, and after that you can judge by the imaging findings. And these are some of the important landmarks. Renal and perirenal abscesses are serious and often misdiagnosed. I see this, I can see in my day practice many candidates or many of my colleagues that can misdiagnose this abscess as a tumor. Then I repeat, you should emphasize the clinical picture and the imaging findings. About 35% of renal and perirenal abscesses are correctly diagnosed in the emergency room. Mortality on these abscesses is about 14%. CT is the best way. The best way is more accurate than ultrasound and MRI in the diagnosis of perinephric abscess, unless you use the diffusion weighted images for evaluation in MRI imaging. Then the treatment is, of course, by broad spectrum antibiotics. If the abscess is larger than 5 centimeter, it needs drainage. Next case is a female patient, 70 years old, and these are the pre-contrast arterial phase, venous phase, coronal, and sagittal. Yes, any possibilities? Oncocytoma, angiomyolipoma, renal cell carcinoma. Yes, the right answer is renal cell carcinoma, which is the most common solid renal mass in the clinical practice. And you see that this is the pre-contrast, and this is the arterial phase with significant enhancement and multiple areas of tumor breakdown and cystic changes. There is no fat to suspect the possibility of angiomyolipoma, and there is no fluid to suspect the possibility of that this is atypical renal cyst. And also do not diagnose a renal oncocytoma even you have the typical CT appearance of the tumor. You should consider the possibility of renal cell carcinoma, and if it proved to be an oncocytoma after that on biopsy, you are not wrong. Then we used in the previous days, if we see a solid mass in the kidney, the clinician says that don't recommend needle biopsy, I will remove the kidney. And it happened that one of the surgeons removed the kidney, and it proved to contain an oncocytoma instead of a renal cell carcinoma. Okay, this is ultrasound and Doppler of the testis. The patient is 16 years old with a painless right testicular mass. Yes, right answer. This is epidermoid, testicular epidermoid, the classic appearance of epidermoid cyst with the characteristic whorly appearance on ultrasound and the absence of internal hypervascularity. The vascularity is around the lesion, not inside the lesion. This is a classic appearance of testicular epidermoid cyst, which is a benign lesion accounting for about 20%, 2% of testicular masses seen in the second to the fourth decade painless, and not tender testicular mass in the range of 1 to 3 centimeter in diameter. The classic appearance on ultrasound, sometimes on MRI, is what's known as lamellated onion scale or word appearance, and there may be some what looks like target appearance. This lesion will not show post-contrast enhancement. Of course, on MRI, you know that epidermoid will show diffusion restriction. But I have mentioned that ultrasound is the best modality for evaluation of the tests. And a few days ago, I have a case of testicular MRI, and I couldn't know what is the exact pathology. I recommended to have a complementary ultrasound, and the pathology was a testicular infarct. Then this is a testicular epidermoid cyst, classic appearance, whorly or onion ring-like configuration with no vascularity on Doppler scan. Next case is a patient with history of scrotal trauma. He is 33 years old. Yes, and this is scrotal hematoma, the classic appearance. There are two lesions that can produce septated multilocular intrascrotal lesion like this. And the first one is hematocele, the second one is biocele. And of course, the differential diagnosis between both is through the clinical data. If the patient had a history of trauma, this is hematocele. If the patient has a swollen scrotal, very painful, very tender, then with fever and so on, then you suspect the biopsy. Then, as I have mentioned, biocele may have a similar appearance. These are only two lesions inside the scrotum having this multilocular configuration. The scrotal hematoma or hematocele and the biocele. And this is another appearance of a hematocele or scrotal hematoma. This is the testicle which is compressed and displaced on the side of the scrotal sac, and you got large multiloculated lesion. Next case is a patient with post partial nephrectomy. This patient was evaluated after partial nephrectomy by CT, which showed this appearance, and by selective angiography, which showed this appearance. What do you think? I know it's not an AV malformation. Aneurysm, yes, and this is what we call a pseudo aneurysm because it is the sequelae of trauma. Where is the trauma? It's a partial nephrectomy. The patient had removed part of the lower bowl of the kidney, and this was followed by a big perinephric hematoma and a small aneurysm. This aneurysm was confirmed by DSA-aided selective renal angiogram, and of course the aneurysm that has resulted from trauma is known as pseudoaneurysm. This case is evaluated for the possibility of renal calculi. He is a male, 61 years old. Left renal cell carcinoma, very good. Actually, this is an important issue that there are calculi, of course, in the calyx, lower calyx of the left kidney. But what's very important is this one. This is a solid renal mass projecting beyond the renal contour which is a renal cell carcinoma. And and this time I would like to emphasize that the triphasic CT is not helpful in the diagnosis of renal masses, especially in the arterial phase, because many of the small renal cell carcinomas can be overlooked because of inadequate opacification of the renal parenchyma. Then you have to emphasize the good delineation of the kidney in the venous phase, or which is known as the nephrographic phase, and in the secretory phase, which is delineating the pelvic cell system, looking for any of the lesions inside the collecting system. Next case, this is the original scan, and this is follow-up study. And what do you think? Dirty fat infection, emphysematous, you mean emphysematous pyelonephritis, maybe, but renal abscess and the drainage, very good. Yes, this is the kidney, which is compressed by these big collections in the perinephric space. The collection showed marginal enhancement and multiple air loculi as well as air fluid level, and this is diagnostic of perinephric abscesses and emphysematous pyelonephritis, and this is the follow-up after conservative treatment by antibiotics. Then I would like from all of you to put into your consideration the possibility of inflammatory renal diseases and not jump on the diagnosis of renal cell carcinoma unless you have the positive findings for the diagnosis. This is a male, 23 years old, with this appearance on ultrasound. This is the urinary bladder, and this is the distal part of the ureter. What do you think? Yes, very good. This is erythrocoel. The answer is right, and this is the appearance on excretory urography. The ureter is markedly dilated with cobra head appearance in the urinary bladder, diagnostic of erythrocoel. Then I see that one answered that this is a stone, but actually the stone will produce posterior acoustic shadowing, and this is not the case here. This is the wall of the erythrocoel against the urine in the urinary bladder. Then I think this will be an easy diagnosis now. Orchitis, yes. And if you see that the testicle is diffusely involved by the pathology, the testicle is swollen, and you see also some vascularity in the epididymis, and this is epididymoorchitis. The epididymoorchitis, you can see enlarged hypoechoic or hyperechoic epididymis. If the lesion is confined only to the epididymis, and there may be reactive hydrocele or biocele. In acute orchitis, you got focal hypoechoic area, diffuse enlargement with heterogeneous echogenicity, and you see that you may got both together in the same patient. Next case is a patient presenting by symptoms of bowel obstruction. He is 71 years old, and this is the CT scan. Yes. This is transitional cell carcinoma. What do you think about this? No, this is not renal vein affection. This is metastatic lymphadenopathy. Then, if you look carefully here, and you can see a mass that is enhancing in the renal pelvis on the right side, and you got para-aortic mass, which represents lymph nodes enlargement related to the renal to this tumor. Next case. Pyelonephritis, yes. This is acute. You have to say this, that this is acute pyelonephritis, because in the chronic pyelonephritis, the kidney is swollen, is small in size, with scarring of the renal parenchyma and distortion of the calyces. But in acute case, the kidney is swollen and it's poor function. You may got striated nephrogram, and you can also see extensive stranding of the perinephric fat. Next case, patient 68 years old, presenting with macroscopic hematuria. Renal cell. Okay, and you got the my advice. Actually, this is the renal cell carcinoma on the right side, and this is oncocytoma. But if you are confronted by a similar case in the exam or in the clinical practice, the bilaterality of renal cell carcinoma is not that well known. But you may say that this is the renal cell carcinoma, this is a metastatic lesion, and because of the central scar and the tumor size, actually I cannot diagnose this as an oncocytoma unless I have the histopathology. But this was proved to be an oncocytoma on the left side and the small renal cell carcinoma on the right side. Next case, it's a female patient, 16 years old. Angiomyolipoma, polycystic kidney disease, renal cyst, lymphoma. Yes, lymphoma is right. These are solid lesions in the kidney, and multiple solid lesions in the kidney may represent one of two, either renal deposits or lymphoma. And lymphoma is more common, of course, than renal deposits. Then these are lymphomatous lesions, and you consider that this very big lesion is also a lymphomatous lesion. And if you look carefully in the retroperitoneum, you can see also lymphomatous lymph nodes. Then the kidney, according to the literature, is the most common abdominal organ affected by lymphoma organ compared to the liver and spleen and so on. It is usually a component of multi-system lymphoma, and the primary renal lymphoma is rare or unusual. Renal lymphoma detected at autopsy, incidence is about 45% in lymphoma patients. If you have a patient with lymphoma, the chance to see lymphoma in the kidney is about 50% at autopsy. Then the incidence by CT is 5%, and the presentation is by flank pain, weight loss, hematuria, and the palpable mass. Renal lymphoma is usually of the non-Hodgkin type. There are four appearances for lymphoma in the kidney. Number one, a solid mass, which is exactly similar to renal cell carcinoma. Multiple masses, which is the easiest form of lymphoma to be diagnosed, without disturbance of the renal contour. Number three is retroperitoneal nodes invading the kidney. And number four is the perinephric tumor infiltration, and this is known as perirenal lymphoma. This is the usual appearance that we can diagnose easily in the clinical practice. The kidneys are swollen, they are infiltrated by multiple solid masses, and these solid masses do not disturb in many cases the renal contour. Then you suspect the possibility of lymphoma. Next case. Diverticulum is, and this is diverticulum. It has a specific name, which is Hutch diverticulum. Hutch diverticulum is a bladder diverticulum that occurs very close to the uretrovesical junction. And because of its location, it may disturb the urine flow through the distal part of the ureter, resulting in proximal back pressure changes. This is known as Hutch diverticulum. And in this particular case, you can also see duplication of the pelvic ileal system, and usually the lower moiety, which may suffer some of the back pressure changes due to ectopic insertion of the ureter in the bladder. Next case. Yes, and this is a straightforward case of angiomyolipoma by CT and by angiography. In the CT scan, you got fat within the mass, and this is essential for the diagnosis. And on the angiogram, you got significant hypervascularity of the lesion with maybe multiple small aneurysms and cross venous fillings and so on. These are the feature diagnostic of angiomyolipoma. Then one of the important features you should look for is the presence of this soft tissue sheet around the kidney, which means that this angiomyolipoma is bleeding, and actually it may require some intervention to stop the bleeding. This is ultrasound of a male patient, 33 years old, and it shows some echogenic structures in the kidney. And there are only two structures that can produce high echogenicity in the kidney, which are fat and air. Then what do you think of this? Oh, stone also. Yes, this is the third possibility. Fat, air, and stone. Staghorn stone, you mean? Other possibilities? No. Okay, and this was air actually in the pelvic ileal system, and the diagnosis is emphysematous pyelonephritis. I think that the air and fat will not produce very evident posterior acoustic shadowing compared to the stones. Then the stones will produce very evident posterior acoustic shadowing. Emphysematous pyelonephritis is a disease that can be diagnosed from the plain film, and you see air in the right renal area. It may affect the renal tissue itself or the perinephric space, and this all the emphysematous lesions, emphysematous pyelonephritis, emphysematous cystitis, emphysematous pancreatitis, emphysematous cholecystitis are more common in patients with diabetes. Then there are some classification. I don't think that you may be interested in this classification, but it is an easy one. Class 1, gas in the collecting system. Class 2, gas in the renal parenchyma. Class 3 is divided into two subgroups. 3A, extension of gas to the perinephric space. 3B, extension of gas to the paranephric space. Of course, you know the difference between perinephric, which is enclosed by the Gerotta fascia, and paranephric is the space outside the Gerotta fascia. Class 4 is bilateral emphysematous pyelonephritis or emphysematous pyelonephritis in a solitary kidney. Next case is this is testicular ultrasound. Yes, testicular microlithiasis. This is right, and you got foci of bright signal with of bright echogenicity in the kidney, in the testicle. This is testicular microlithiasis, and this is a common condition resulting from deposition of tiny calcium in the testicles, unilateral or bilateral, and the incidence is about with 0.5% in patients doing a scrotal ultrasound. Testicular microlithiasis is seen in 50% of patients with germ cell tumors. You know that seminoma is associated or can occur in a testicle that has involved by testicular microlithiasis, and the lesions range from 1 to 3 millimeter in size. There are also some grading according to the number of the bright foci. From 5 to 10, grade 1, from 11 to 20, grade 2, from 21 to 30, grade 3, about above 30, and you consider grade 4. Next case. This is actually a child. This is not a male 33, but this is a child with this catheter in the urinary bladder, indicating that you are dealing with an ascending cystourethrogram. And then grade 5, vesiculoreteric reflux. And what about on the right side? It's grade 3. Yes, grade 3 vesiculoreteric reflux on the right side, and grade 5 because of the dilatation and tortuosity of the ureter on the left side. Then this patient had this CT scan. Mm, Very good. Reham said that this is an infarction, and this is an answer which is right. This is renal infarction because of a thrombus in the aorta, not in the renal vein. This is the aorta, and this is the IVC. The IVC is patent, and you do not see the renal vein on the right side. Then this is a thrombus in the aorta that has affected the right renal artery, resulted in this renal infarction. Okay, next case. Bosniak type 3 renal cyst, and actually you do not see the kidney on the right side. Chronic pyelonephritis, yes, it looks a reasonable answer, but I said to you many times that whenever you see calcium in the renal parenchyma, you should suspect the possibility of TB. Infection of the kidney by TB is a form of chronic pyelonephritis. Yes, you are right. But in this particular case, you do not see evidence of significant renal parenchyma. You see parenchymal calcification, and you should think of, if you say that this is chronic pyelonephritis, okay, but it's more better to say that this is renal TB. Next case. Left pyelonephritis, acute pyelonephritis. Okay, this is right, and this is pyelonephritic kidney. The kidney is swollen, the kidney is relatively of poor function, and there are some striations of the nephrogram, and this is acute pyelonephritis. Next case. Renal abscess and renal cell carcinoma. Okay, and if you look carefully here, and you can see that the kidney is involved by a lesion of heterogeneous density. There are some solid components, and also you can see in the coronal image that the inferior vena cava is not opacified and is filled by a soft tissue density that is more or less similar to this one. Then you are dealing with renal cell carcinoma with invasion, of course, of the renal vein, then invasion of the IVC. Next case. Angiomyolipoma, tuberous sclerosis, METS. Alhamdulillah. METS. If you look carefully for the history, this patient had lung carcinoma. I will repeat and emphasize, if you know that the patient had a primary malignancy, you should put this knowledge into the prime consideration. Then, if the lesions in the kidney and the liver can fit with metastasis, of course, this is the diagnosis. And these lesions can fit, of course, with deposits, and you got renal metastasis and also hepatic deposits. Renal metastases are usually detected at autopsy, and this is the incidence in a large series, about 12%. The most common primaries are the lung and the breast. Also, GIT and melanoma can metastasize to the kidney. And renal metastases occur late in the course of the disease. Metastases are usually small, multifocal, and bilateral, almost similar to those seen in lymphoma. But in lymphoma, you do not have the history of positive primary malignancy. Mild enhancement less than the normal kidney. If the renal metastasis presented as a solitary lesion, you can never discriminate it from the renal cell carcinoma. But whenever you know that the patient had a primary malignancy, you should stick for the possibility of metastasis rather than to diagnose double primary in the patient. This patient with lung cancer and a renal mass on the right side, bulky retroperitoneal lymphadenopathy, all these are metastatic deposits. This is the initial scan, and this is the follow-up scan. You got much progression of the renal lesion with development of retroperitoneal lymphadenopathy. Next case. Yes, and this is bladder cancer, transitional cell carcinoma of the urinary bladder, but the multifocal type. Of course, you know that the bladder cancer can occur as a solitary bulboid lesion or diffuse non-uniform mural thickening or multiple bulboid lesions in the urinary bladder. Okay. And this is the carcinoma. The serial carcinoma has the propensity for multicenteric, you mean multiple lesions inside the urinary bladder, either synchronous or metasynchronous. In the upper and lower urinary tracts, you know that urothelial cancer can affect the ureter and the pelvic cell system as well, and the superficial lesions do not invade the muscularis propria. The deep lesions invade the muscularis propria, and the tumor may metastasize to the lung, liver, and bone. And this is a bladder cancer with multifocal appearance, a big mass along the anterolateral aspect of the bladder, another mass here, non-uniform mural thickness, and a calcified mass in the back of the bladder. Next case. Renal cell carcinoma. Other possibilities: angiomyolipoma, acute pyelonephritis. Yes, acute pyelonephritis with abscesses. Angiomyolipoma is diagnosed by the presence of fat. Renal cell carcinoma is diagnosed by the presence of a focal mass in the kidney and projecting outside the kidney maybe, but in this condition the kidney itself is swollen and the function is relatively poor, and you got multiple areas of collections within the renal parenchyma, and you see a stranding of the perinephric fat. All these conditions or the findings are supportive of the diagnosis of acute pyelonephritis. I hope that if this case is present in the clinical practice or in the exam, you will write the accurate answer. This is a child 3 months old, presented by this appearance, very huge bilateral hydronephrosis and dilated tortuous ureters, bilateral vesico-ureteric reflux, grade 5 reflux, and the diagnosis of reflux. But I will drive your attention to, if a child at this age presented by this configuration, think of a posterior urethral valve, because the reflux in this very early age will not reach this huge size, but the obstruction at the bladder neck or in the urethra may result in this appearance. Then number one, you should emphasize that this is a male child. Number two, you see that it is newborn or an infant. Number three, you got advanced hydronephrosis that is bilateral and also hydroureters. Next case. Yes, this is an easy case of xanthogranulomatous pyelonephritis because of the enlargement of the kidney and the staghorn stone, and multiple abscesses within the renal parenchyma. This is an easy diagnosis of emphysematous pyelonephritis and densogranulomatous pyelonephritis. This is an unusual form of chronic pyelonephritis, and it is relatively common in middle-aged women, especially the diabetics. It is usually unilateral and destroys the kidney, requiring nephrectomy. The Staghorn calculus is not an essential finding for the diagnosis since it occurs in about 75% of the cases. And one of the classic appearances of densogranulomatous pyelonephritis is the Beerbaum sign, which is the stone and the dilated collecting system simulating this appearance. Next case. Yes. Yes, this is renal cell carcinoma. The answer is right, and you got solid mass in the right kidney, but these are simple cysts. And you see, these are simple cysts. Maybe the image is not that good, but you got cystic lesions on the left side, solid mass on the right side, and the stone in the gallbladder as well. Yes. No, this is not lymphangiectasia. And in cases of lymphangiectasia, you should, yes, the answer is parapelvic cyst or peripelvic cysts. In cases of lymphangiectasia due to obstruction of the renal lymphatics, you got fluid in the perinephric space as well as in the renal hilum. But this is cyst filled with fluid going in between the calyces, and this is very pelvic cysts. And the cyst, if the cyst is located at the renal hilum, displacing the calyces to one side, this is parapelvic. But if the cyst is insinuated between the calyces, this is peripelvic. And the renal sinus cysts, we have parapelvic and peripelvic, and these are not in the classification of Bosniak, but they are independently classified separately. Yes, and this is emphysematous pyelonephritis, a straightforward case with the gas infiltrating or involving most of the renal parenchymal tissue. There is a small remnant of the kidney, but most of the kidney is replaced by gas. Next case. Yes, very good. This is angiomyolipoma. You see the fat-containing lesion along the anterior aspect of the left kidney with internal hypervascularity seen in the arterial phase. And actually, in the pre-contrast scans, you can easily diagnose the lesion. And in the nephrographic phase or the venous phase, you can also easily diagnose the lesion. I do not recommend the triphasic scans for evaluation of the kidney or the pancreas. They are only helpful in evaluation of solid hepatic masses. Next case. vein thrombosis. And what about the kidney? Yes, and this is renal cell carcinoma on the right side, invading the renal vein as well as the IVC. You see the tumor thrombus in the big tumor thrombus in the IVC, and there is extension through, of course, the renal vein into the IVC. This is renal cell carcinoma with invasion of the renal vein and the IVC. This is a child, 13 years old. No answer. Okay, and you have a multilocular cystic lesion in the left kidney with no apparent mural nodules, and this is right answer. Multicystic nephroma or multilocular nephroma. This is right. Or grade 3 Bosniak classification. This is multilocular cystic nephroma. The origin of this nephroma is not known. You got multilocular cystic lesions, and you have two incidents for this tumor at the childhood and also in the adult age. You may got some calcification in the lesions, but the lesion has a typical appearance on the CT and ultrasound in the form of a big cyst, which is multilocular, containing fluid density with no mural nodules. Next case. This is a male, 23 years old. This is the initial scan, and this is the follow-up after 3 years. Yes. Surrounding urinoma, surrounding what? And in the initial scan, you see a huge dilatation of the calyces and renal pelvis, diagnostic of pelvic junction obstruction. And this case was followed. Then you got rupture of some of the calyces or maybe the renal pelvis with the development of perinephric collection, which is known as perinephric urinome. Okay. Next case, female, 23 years old with hypotension, right-sided back pain, blood count revealed hemoglobin, so and so. And this is the mean corpuscular volume compatible with acute hemorrhage. Tuberous sclerosis, bleeding from giant angiomyolipoma, yes. And there are bilateral angiomyolipomas, and a huge one on the right side, which is bleeding tumor. Then actually, if you see bilateral angiomyolipoma, you think of tuberous sclerosis, of course, because this is one of the pathognomonic criteria for the tuberous sclerosis. And this is an MRI of the prostate, male, 55 years old. Yes, prostatic cancer in the central zone, very good. This is a central zone prostatic carcinoma. And you can see that this is the area that is affected by tumor, which is of low signal and the central zone, and diffusion restriction, bright in the diffusion weighted images, restricted in the ADC image. Then the diagnosis of prostatic cancer in the central zone, then this is relatively rare compared to the cancer occurring in the peripheral zone. And this patient had a transplanted kidney. You can see that in the stage kidneys, and this is the transplanted kidney with decreased urine output, chronic line pain, and the features of transplant failure. Biliary obstruction, angiomyolipoma, lipomatosis, yes, replacement lipomatosis. You remember that in kidneys that are chronically obstructed or chronically infected, the kidney may be replaced by fat, and this is the case where you can see that the transplanted kidney, there it is almost totally replaced by fat, except for this rim of renal parenchymal tissue, and this is what we call atrophic changes of the kidney or replacement lipomatosis. And you remember that I have mentioned this before, and it may be the sequelae of xanthogranulomatous pyelonephritis, as in this case, where you can see a big stone and absence of renal tissue. Only you can see fat. And you remember, we have mentioned this before, that if you got staghorn stone and you got obstructive changes in the kidney followed by infection and the chronic pyelonephritic changes, which may proceed to xanthogranulomatous pyelonephritis, which is a variant of chronic pyelonephritis, and finally the kidney may be replaced by fat, which is known as replacement lipomatosis. And this is the replacement lipomatosis. The kidney is replaced by fat. It is considered as a severe form of renal sinus lipomatosis. Sometimes you can consider this, and is associated with long-standing infection and calculi in about 75% of the cases. Renal replacement lipomatosis and xanthogranulomatous pyelonephritis may occur simultaneously, of course, starting by xanthogranulomatous followed by replacement lipomatosis. And these are some of the explanations of the deposition of fat. Next case. Yes, this is right. This is a TB of the kidney, and you can see the almost destruction of the renal parenchyma on both sides. But what is very important is the presence of calcium in the renal parenchyma, and also if you look carefully here, you got strictures in the ureter, and this asterisks point to the bladder, which is severely contracted and of reduced capacity. Then all these manifestations are the sequelae of urinary tuberculosis. And urinary tuberculosis accounts for about 20% of extrapulmonary TB, and it can affect the renal parenchyma and the collecting system. The non-specific clinical pictures include hematuria, flank pain, constitutional symptoms. but one of the best diagnostic clues for tuberculosis of the urinary system is sterile biuria. And you got pus in the urine. If you look for organisms, you do not see any organism. This is very important. And if you got sterile biuria, then you have to screen the urinary tract for the possibility of TB. Then the final stage of renal tuberculosis is the presence of a small, totally calcified kidney, which is known as body kidney or O2 nephrectomy. Next case. Renal abscess and focal nephronia and no, this is not IVC. This is the renal vein. It's not IVC. The IVC is good, but the renal vein is obliterated by a thrombus. And you see here this linear filling defect in the renal vein. This is renal abscess and renal vein thrombosis. This patient presented by flank pain and hematuria. No, this is not transitional cell carcinoma. You do not see a mass in the collecting system. You see only that the renal vein is thrombosed. And in cases of renal vein thrombosis, you got some swelling of the kidney, and you got some stranding of the perinephric fat, and you got relative poor function of the kidney. There are three acute conditions that present the same finding. The findings are: number one, a swollen kidney, poor renal function, stranding of the perinephric fat. The three conditions are acute pyelonephritis, acute glomerulonephritis, and renal vein thrombosis. And this is a renal vein thrombosis. Of course, renal vein thrombosis can occur without the presence of any malignancies, like in females with contraceptive pills and dehydration and all the causes of venous thrombosis. These are the causes like spontaneous, secondary to trauma, severe dehydration, nephrotic syndrome, renal cell with tumor thrombus, hereditary and acquired hypercoagulable state, and oral contraceptive pills. Next case. Yes, this is hydatid cyst, classic appearance, and you got marginal calcification with internal daughter cysts. The appearance is clear in the coronal image, but it's misleading in the axial image because of the compression of the renal pelvis and the dilatation of the calyces. But this is a renal hydatid cyst. The renal hydatid cyst is considered by literature is an extremely rare pathology seen in less than 5% of patients with hydatid disease. Of course, the common sites are the lung, liver, and spleen, but many of the organs can also be involved. The classic appearance of hydatid cysts are one of three: cyst with calcification of its wall, cyst with internal floating shadows, cyst with internal daughter cysts inside. Next case, male, 63 years old, MR of the prostate. Yes, carcinoma of the prostate on the right side with extra prostatic extension invading the neurovascular bundle on the right side. This is the right answer. Ultrasound and the Doppler of the prostate in a male 53 years old. Prostatitis. Benign prostatic enlargement. Actually, this is normal. Normal ultrasound of the prostate. And ultrasound is a very good diagnostic modality in the testes, but it is not that good in the prostate. Next case. Yes, this is the classic appearance of oncocytoma. But as I have mentioned before, that you should be careful in the diagnosis of oncocytoma. You first, if you are in the exam, you say that I am dealing with a solid mass in the upper bowl of the kidney. And the most common solid mass in the kidney is renal cell carcinoma. Then if you are asked about the differential diagnosis, you may mention oncocytoma because of the presence of a central scar, which is one of the criteria of oncocytoma. This case has proved to be oncocytoma. Next case. Yes, this is renal cell carcinoma on the left side, and you got a solid enhancing mass projecting from the anterior aspect of the kidney, diagnostic of renal cell carcinoma. Next case. And no evidence of hepatic metastasis, and if you are considering this very small lesion, I don't think that this is metastasis. Okay, but in the second case, TB, very good. Calcium in the urinary tract means TB, and I see extensive calcification in the kidney and in the ureter, then you know that you are dealing with a case of urinary tuberculosis. CT of the scrotum. No, no, this is not epidermoid and not emphysematous orchitis. This is the testicle, and the scrotum is filled by fluid, and there is an enhancing margin with air luculi inside, and there is no history of trauma to suspect hematoma, then you are left with a scrotal abscess, as Manal said. This is a scrotal abscess on the right side. This is the left hemiscrotum, which is normal. And then in this condition, you got pus inside the scrotum, and this is a scrotal abscess. Then next case is a male 30 years old with, I will say the findings to help you to reach the diagnosis, or you may reach the diagnosis by yourself. First, we see your trials. Of course, in the previous case, the testis is not normal, it's surrounded by pus. Then you got edematous changes, ischemic changes, and so on. Then, yes, Reham, very good. Yeah, Reham, this is von Hippel-Lindau syndrome. You got multiple pancreatic cysts, and you got bilateral renal masses representing renal cell carcinomas. And the combination of these findings emphasize or drive your attention to the diagnosis of von Hippel-Lindau syndrome. Next case. And here, I don't know if you can see the findings, but I hope you see the findings here. Also, Hanin said that this is vulnerable. Good answer, very good. Any possibility for this case? Okay, then you see here that the left kidney is replaced by this shadow, which is cystic non-functioning renal tissue. And lower down, you can see that there is a cyst in the seminal vesicle. Then you are dealing with a congenital abnormality and on the left side in the form of multicystic dysplastic kidney and seminal vesicle cyst. Also, you got portal cavernoma, which is not related to these congenital abnormalities. And thank you very much.